Welcome to StudyNeuro. In this presentation, we will discuss the preoperative evaluation of posterior communicating artery aneurysms with a focus on clinical assessment, imaging, and the surgical planning principles that guide safe and effective treatment. Preparation begins well before surgery. We will review the key clinical features and risk factors, as well as the role of imaging modalities such as computed tomography angiography, magnetic resonance angiography, and digital subtraction angiography in defining aneurysm anatomy and guiding treatment strategy. Special attention will be given to vascular variants, including the fetal posterior cerebral artery, as these anatomical patterns can significantly influence both surgical clipping and endovascular planning. We will also examine how imaging findings inform treatment selection between clipping and endovascular therapy, along with the role of additional investigations and perioperative preparation in improving patient safety and clinical outcomes. Follow StudyNeuro across YouTube, Facebook, TikTok, Instagram, X for focused neuroscience education and practical clinical insights. Preoperative evaluation is a critical step before treating posterior communicating artery aneurysms because it provides the anatomical and clinical information needed to guide safe surgical or endovascular intervention. Careful assessment helps define aneurysm anatomy, determine whether rupture has occurred, and estimate the overall technical difficulty of treatment planning. Preparation strongly influences outcomes. Detailed preoperative planning also helps reduce operative complications, lower the risk of ischemic injury, and minimize the chance of intraoperative rupture, especially in aneurysms located close to important perforating vessels and cranial nerves within the paracellar region. The main goals of evaluation are broad but closely related. Clinicians must first confirm the diagnosis and identify evidence of hemorrhage, while also carefully defining aneurysm morphology, assessing vascular anatomy and anatomical variants, and evaluating whether the patient is medically fit for intervention during a period when neurological status may change rapidly. Treatment selection is equally important. Determining whether microsurgical clipping or endovascular therapy is more suitable depends on aneurysm configuration, vascular relationships, and overall patient condition before intervention begins. Clinical history is a fundamental part of preoperative evaluation because many patients with posterior communicating artery aneurysms present with symptoms that suggest rupture, cranial nerve compression, or previous neurological injury. Important historical features include sudden severe headache, double vision, drooping of the eyelid, seizures, or evidence of prior hemorrhagic events during earlier clinical episodes. Risk assessment is equally important. Several patient-related factors increase the likelihood of aneurysm formation and rupture, including long-standing hypertension, cigarette smoking, female sex, a positive family history of intracranial aneurysms, and inherited conditions such as polycystic kidney disease, all of which may influence both disease progression and long-term vascular risk. Comorbid medical conditions must also be reviewed carefully before intervention. Cardiac disease, respiratory disorders, renal impairment, and other systemic illnesses can significantly affect anesthetic safety, surgical tolerance, and overall perioperative management during aneurysm treatment. Neurological examination is essential during preoperative assessment because it establishes the patient's current neurological status and helps identify signs of aneurysm rupture, raised intracranial pressure, or focal brain injury before treatment begins. Clinicians carefully assess the level of consciousness using the Glasgow Coma Scale, next to pupillary responses, cranial nerve function, motor strength, and signs of meningeal irritation during the initial evaluation. Certain findings are especially important. Third nerve palsy strongly suggests compression from a posterior communicating artery aneurysm, particularly when patients develop ptosis, pupillary dilation, and impaired eye movement due to involvement of the oculomotor nerve as the aneurysm enlarges near the paracellar region. A detailed baseline examination also provides an important point of comparison after surgery or endovascular treatment. This helps clinicians recognize new neurological deficits early and evaluate post-operative recovery more accurately during ongoing monitoring. Clinical grading systems are important during the preoperative evaluation of ruptured posterior communicating artery aneurysms because they help quantify neurological severity and estimate the overall risk of complications before intervention begins. Commonly used systems include the Hunt and Hess scale, the World Federation of Neurosurgical Societies grading system, and the Fisher grading scale based on the extent of subarachnoid seen on imaging. These grades influence major decisions. Clinical grading helps predict patient prognosis, guides the timing of surgical or endovascular intervention, and assists clinicians in determining the level of postoperative monitoring and intensive care support required, particularly in patients with severe hemorrhage or rapidly changing neurological status during the acute phase of management. Computed tomography is the first-line imaging test in suspected subarachnoidhemorrhage because it quickly identifies acute bleeding within the subarachnoid space, associated hydrocephalus, and surrounding mass effect on brain structures. CT findings also help clinicians judge how severe the hemorrhage is and whether immediate intervention is required, especially when pressure effects or ventricular enlargement suggest a higher risk situation. Findings guide urgent clinical management decisions. Lumbar puncture comes next in selected cases. When computed tomography shows no bleeding but clinical suspicion for subarachnoid hemorrhage remains high, lumbar puncture is performed to look for hidden blood in the cerebrospinal fluid and confirm diagnosis. It helps detect subtle bleeding changes. Xanthochromia is a yellow discoloration of cerebrospinal fluid caused by breakdown of blood, and it can reveal bleeding that is not visible on imaging, especially when presentation is delayed after the initial event. Vascular imaging guides clinical diagnosis decisions. Computed tomography angiography, known as CTA, and magnetic resonance angiography, or MRA, are imaging techniques used to visualize cerebral blood vessels in suspected aneurysmal or other vascular disease conditions. It helps detect aneurysms and provides detailed vascular mapping for surgical or endovascular planning in suspected subarachnoid hemorrhage. It also helps screen unruptured aneurysms. The benefits are practical in clinical use. CTA and MRA are non-invasive imaging methods that allow rapid acquisition of vascular information and are commonly used in emergency and outpatient neurovascular assessment settings. These tools are widely available in many centers. Digital subtraction angiography is central in vascular diagnosis. This is the gold standard test. It provides the highest level of vascular detail using selective arterial catheter injections with rotational and three-dimensional imaging that together allow dynamic assessment of cerebral blood flow in real time. It is essential for surgical planning. Clinicians rely on this technique next to other imaging studies because it defines aneurysm anatomy with precision and supports safe operative planning by showing vessel relationships and critical branching patterns before intervention. Collateral circulation is carefully evaluated here. During angiography, the ipsilateral internal carotid artery is temporarily compressed while contrast is injected from the opposite side, allowing clinicians to assess collateral blood flow and predict tolerance to temporary clipping in complex aneurysm cases. Morphological analysis focuses on how an aneurysm looks and behaves within the vessel system. It starts with basic structural description, including its size, exact location, and the direction the dome is pointing, along with its overall shape and how the neck is formed where it connects to the parent artery. These features are assessed together because they define the aneurysm's geometry and its interaction with surrounding vessels. This is critical information. Attention then shifts to nearby anatomy. Clinicians examine how the aneurysm relates to the parent artery and small perforating vessels, because even minor variations in these relationships can affect surgical access and safety, especially when working in tight neurovascular corridors where small errors can lead to significant ischemic risk. Finally, subtle surface changes are considered. Irregular lobulations or small daughter sacs often suggest structural weakness in the aneurysm wall, and this increases both rupture risk and procedural difficulty during clipping or endovascular treatment planning design. These morphological details directly shape management decisions. They influence whether microsurgical clipping is feasible, whether endovascular coiling is safer, and how carefully nearby vessels must be preserved to avoid complications during treatment.
Assessment of vascular variance is an essential step before any intervention. It is never optional. Key anatomical variations in the posterior circulation are first identified, including a fetal type posterior cerebral artery and a hypoplastic P1 segment, because these patterns change how blood reaches the brain and can shift the overall hemodynamic balance within the circle of Willis in ways that are not always obvious on routine review. Branch vessel involvement is also evaluated with care. When important arterial branches arise from or are closely incorporated into an aneurysm, treatment becomes more complex, and preservation of these vessels is critical, since they may be supplying functional brain tissue that cannot tolerate reduced flow. A fetal posterior cerebral artery is especially important. In this variant, the posterior cerebral artery receives most of its blood supply from the internal carotid system, so any intervention near the carotid circulation must account for this dependency to avoid unintended ischemic injury. Assessment of vessel wall characteristics is a key part of preoperative imaging. It matters more than it looks. CT and CT angiography help identify structural changes within the arterial wall, including calcification, atherosclerotic change, and sometimes intraluminal thrombus. And these findings give important clues about vessel fragility and how the aneurysm has evolved over time. Calcified aneurysms behave differently during treatment. They are often more difficult to clip because the wall is rigid, and there is a higher chance of narrowing the parent vessel during manipulation, which can compromise blood flow if not carefully anticipated. These features also influence treatment choice. In many cases, heavy calcification shifts the decision toward endovascular strategies, especially when microsurgical dissection carries a higher procedural risk due to reduced vessel compliance and limited ability to reshape the aneurysm safely.
Ancillary investigations support safe treatment planning. They are often overlooked but important. Basic laboratory tests are done to assess overall physiological status before intervention, including blood counts, serum electrolytes, and coagulation function, because even small abnormalities in these parameters can influence bleeding risk and perioperative stability in neurosurgical patients. Cardiac evaluation is also included when needed. An electrocardiogram is commonly performed, and echocardiography may be added in selected cases where cardiac function needs closer assessment, especially in patients with known or suspected cardiac disease that could affect anesthesia tolerance. Other preoperative checks complete the assessment. Chest imaging and anesthesia review help ensure the patient is fit for surgery. And together, these steps reduce perioperative risk by identifying hidden issues that might otherwise make recovery more difficult or unpredictable.
Treatment selection begins with combining all available clinical information. It is a synthesis, not a single decision point. Clinical condition, imaging findings, rupture status, and patient-related medical conditions are considered together, because each factor can shift the balance between risk and benefit in a different direction, especially when urgency and neurological stability must be weighed against procedural safety. Two main treatment paths are usually considered. Microsurgical clipping and endovascular techniques such as coiling or stenting are evaluated based on aneurysm anatomy, accessibility, and overall patient risk profile, with the choice often depending on which method can secure the aneurysm while minimizing harm to surrounding brain tissue and vessels. The final aim is consistent:
The goal is complete and safe exclusion of the aneurysm from circulation while preserving normal vessel function, ensuring long-term protection from rebleeding without introducing new neurological deficits during or after treatment.
In summary, careful preoperative evaluation is the basis of successful management of posterior communicating artery aneurysms. It is the step that sets everything else in motion. Clinical assessment and imaging findings are interpreted together because symptoms alone are not enough and imaging alone is not enough. And only by combining both can a clear and reliable picture of the aneurysm and its clinical impact be formed before any treatment decisions are made. Digital subtraction angiography remains the reference standard for defining vascular anatomy. It gives the clearest and most detailed view of aneurysm structure, which is essential when planning either microsurgical clipping or endovascular treatment in anatomically complex and high-risk regions. Attention to vascular variants and small perforating vessels is critical. These structures may be subtle, but injury to them can lead to serious neurological deficit, especially in tight vascular spaces where there is little room for error or compensation. When evaluation is thorough, outcomes improve. Good planning reduces procedural risk and supports safer surgery, with better chances of preserving neurological function and achieving stable long-term recovery after treatment. This is StudyNeuro. Stay connected for focused neuroscience education and clinical insights across YouTube, Facebook, TikTok, Instagram, and X. Thanks for watching.